متهم بان هو عنده ديبريشن، وهي الحكايه بتبقى اورجانيستي، فلازم ننتبه للتفرقه دي في شغلنا. والميديكيشنز احيانا هي نفسها اللي بتدخله في الديبريشن، يعني احيانا بعض الانتي هايبرتنسفز بتعمل ديبريشن، وزي الريزربين كان بيستخدم كتير زمان، ودلوقتي الاستيرويدز بتستخدم كتير في الميديكال براكتس. ويا اما احيانا بعض الناس اللي بيبقوا اون امفيتامينز ونيجي نعمل لها وذرول يدخل في يعني. واحنا داخلين على الديبريشن ان ميديكال براكتس لازم ننتبه الى ان هناك ايضا اسباب ممكن تدخل المريض في ديبريشن، وقد تكون هيدروجينيك، يعني احنا اللي عاملينها، وبالتالي احنا ننتبه لكده وناخد الهيستوري كويس قوي من المريض واحنا نفحصه. The most common CNS side effect of a drug is confusion or delirium, and this is commonly labeled as depression. يعني ناخد بالنا ان استخدامات الدراجز برضو احيانا بتمس دياجنوز الموضوع. abnormal laboratory values، يعني هنا واحنا بنتكلم على depression in medical practice برضو زي ما بنتكلم عليها في السايكاتري، ناخد بالنا من حاجات زي الثيرويد. يعني الثيرويد فانكشن ممكن تكون هي السبب، الثيرويد والباراثيرويد، وممكن احيانا بيبقى الاشرنج ساين في حاجات زي اللنج كانسر ديبريشن. قبل ما اللنج كانسر كارسينوما تشخص بتبقى الديبريشن هي الليدنج، وطبعا تبقى يعني صعب جدا تشخيصها في المراحل الاولى، انما مع جود هيستوري ممكن نوصل الى هذا الكلام. Other medical conditions that can produce changes of affect and that progress to full syndrome of major depressive disorder، الستروك. فالستروك دايما بندخل احيانا في ديبريشن، والديمنشيا كذلك، والكاردياك ديسوردرز برضه سو فيمس بالنسبه لهذا. الديسبوندنسي دي كلمه بنقولها كونسيكونت لما المريض من الناحيه الفيزيكال بيعاني من حاله شديده جدا، وبتؤدي الى psychic damage done by the disease to the patient's self-esteem. يعني طول الوقت بيعاني من آلام مبرحة، advanced cancer وميتاستاتيك، عامل مشاكل. في النهاية بيبقى المريض in agony، ولما بيبقى المريض in agony حالته النفسية طبعا بتتدهور، وممكن يبقى نقول قد يكون ده depression. انواع اخرى غير الميجور ديبريشن احنا عارفينها زي الديسايميك ديسوردر، وده بيبقى مايلدر سيمبتومز بس كرونيك، يعني بتاخد وقت طويل not less than 2 years. الادجستمنت ديسوردرز with depressed mood، يعني برضو دي هنفهمها من الهيستوري، ده مراته تعبانه، ده عايش في بيت فيه مشاكل الى اخره. ممكن نجد او في شغله في بعض الاستريسز العاليه جدا بتدخله في الادجستمنت ديسوردر. والبريفمنت اللي احنا عارفين ان بعد اللوسز اللي احنا بنمر بيها، حد مات ابوه، حد ضاعت منه وظيفه، طلق، هو يعني انفصل عن زوجته، ودي من الاسباب الميجور قوي في الاول اللي ممكن تدخل واحد في ديبريشن. كتير طبعا من المرضى المكتئبين هنجدهم عندهم كوموربيد كونديشنز، وكوموربيد بتعني هنا ان هو ديبريشن بس عنده ارثرايتس، ديبريشن بس عنده باك ايه، عنده دايابيتس ميليتس، عنده هارت بروبلمز، عنده كرونيك ميديكال كونديشنز، وهي دي اللي بتبقى يعني بتاخد مده لا تقل عن 6 اشهر، واللايف تايم بريفالنس بتاعتها في المود ديسوردرز بتبقى عاليه. الكرونيك اند disabling physical illnesses are at higher risk of depressive disorders with rates ممكن توصل more than 20% among patients hospitalized with chronic artery disease، و30% present with at least some degree of depression. واضح ان احنا كل ما نقرب من الميديسن نلاقي الكارديولوجي واخد الايه الليد. مش بس الكارديولوجي، الدايابيتس، كتير من الجماعه الدايابيتكس هنجد ان عندهم مشاكل نفسيه على راسها الاكتئاب، وخاصه لو الدايابيتس مش كنترول. يعني ايه مش كنترول؟ يعني طالع نازل نازل طالع، وما فيش اي قدره على ان احنا نكنترول، وبيلاقوا الدبريشن بيوصل من 20 ل 32% في الانكنترول تايب اوف دايابيتس. الدبريشن از اولسو كومن في الاوبيز بيشنتس، وعشان كده هتلاقي ان احنا لازم ناخد بالنا ان الاوبيزيتي بقت مشكله كمان. وفي اليو اس جنرال هوسبيتال the psychiatric consultant called to see a medical patient with depression في حوالي 20% من الحالات. Making major depressive disorder the most common problem seen in diagnostic evaluation and treatment. كنت انا في نيويورك في فتره كده، كنت بزور مركز للكانسر في نيويورك، وبعدين بس يعني بشوف السيستم ماشي ازاي، وعشان الزياره نقدر يعني نعملها. وكان من الحاجات الظريفه جدا ان السايكاتريك ايفالويشن نمره واحد. يعني اي مريض داخل في الانستيتيوت، هي اصلا كانسر انستيتيوت، لازم يبقى اسيست سايكولوجيكالي قبل. بجانب بقى طبعا ان كل السكشنز بتبقى بتتعامل مع بعض بكونكشن سريع جدا، وممكن السايكاتريست ينطلق بالتليفون عشان يزور اي مريض في اي لحظه في هذا المبنى الضخم جدا، حوالي يمكن 15 دور، انما السايكاتري كان واخد دور ضخم جدا. هنا عندنا في معهد الاورام القومي اللي هو بيتصلح دلوقتي، بيعملوا فيه تصليحات. كان ليا حظ ان انا وانا رئيس القسم ان انا اتواصل معاهم تواصل جيد، وكان يميع العميد صديق عزيز، ورحب جدا بان احنا نبدا نعمل عياده سايكاتري في معهد الاورام. وبناء على كده ابتدينا مش بس عياده السايكاتري، ابتدينا نعمل ريسيرش معاهم، وعملنا اظن في فتره وجودي هنا في هذه المرحله كانت من 2000 ل 2002 حوالي 4 رسائل دكتوراه واكثر من رساله ماجستير، ومنهم عندنا الدكتور محمد عزت رسالته كانت على الكانسر،
على فخري على فخري
وآل فخري وكثيرين. يعني احنا مهمتنا في السايكاتري ان احنا مش نبعد عن التخصصات الثانيه، لا نروح في قلبهم، ندخل في وسطهم، ولما بيقتنعوا بينا بنقدر نعمل الليزون سايكاتري بشكل جيد. وكان من نفسهم ان هذه التجربه تستمر، بس للاسف طبعا مع تغير الرئاسات والاهتمامات الموضوع ما بقاش بنفس القدر. الكرونيك ميديكال كونديشنز في الديبريسد بيشنتس، يعني العكس بقى، احنا بنقول طب الديبريشن بيبقى معاه امراض اخرى. بنلاقوا ان كثير من المرضى المكتئبين ممكن يبقى عندهم كمان كوموربيد كرونيك ميديكال كونديشنز، والديبريشن بيجي كورس اوف كونكوميتنت ميديكال ديزيز. يعني بيأثر على الكورس. يعني نفرض مريض وعنده كوروناري، عنده ذبح وعنده جلطه في القلب، ده المريض ده ممكن يبقى مصيره ايه لو هو مش ديبريست. ولو هو ديبريست هنجد ان ممكن قوي الفيت بتاعه يبقى الموت 3 أضعاف. يعني لو احنا ما انتبهناش ان هو عنده جلطه في القلب وعنده ديبريشن في نفس الوقت، ممكن يبقى يعني سنفقد السيطره عليه، وممكن يبقى الفيت بتاعه سيء جدا. The more severe the illness, the more likely depression is to be complicated. Mortality in hospitalized patients with coronary artery disease and with continuing depression for at least the first year after hospitalization. حتى بعد ما يطلع من المستشفى بتاع الكوروناري ده ممكن برضه الديبريشن لو معاه وملاحقه المشكله تبقى مضاعفه، ولازم ننتبه لها. ويبقى التوصيه ان احنا هنعالجه، هم بتوع الكارديولوجي بيعالجوا، واحنا في السايكاتري قريبين منهم. في الكاردياك سيرجري مع ميجر ديبريسيف ديسوردر بتنكريز ذا تشانس اوف فيتال اوت. فاذا ده يورينا ان في كل الاقسام الثانيه مسؤوليتنا احنا نقرب منهم، لان للاسف كثير من الفروع الطب الاخرى بيبقوا مش اوير قوي بالامباكت بتاع السايكاتريك كونديشن. ومن مهمتنا ان احنا نعمل يعني جلسات وندوات والى اخره مع الاقسام الاخرى، يعني بحيث ان هم يبدا تدريجيا، لان بعضهم احيانا بيريزيست. بعض الزملاء في الفروع الثانيه اما تقول له سايكاتري ما بياخدش الموضوع سيريسلي، وبعضهم يعني لا يهتم. Myocardial infarction depression in the first 24 hours significantly increase زي ما انا قلت risk of early death و reinfarction or cardiac arrest. فاذا لابد ان احنا ننتبه لهذا الكلام. و risk of mortality في cardiovascular disease depressed outpatient is more than doubled. يعني ده في الانبيشنت اللي دخل يعني النسبه عاليه جدا، وايفن في الاوت بيشنت النسبه ضعف. والانكريزد cardiac mortality with either major depression او minor depression is in large community cohort of individuals with cardiac disease برضه معروفه. Subjects without cardiac disease but with depression have a higher risk of cardiac mortality. فزي ما بنقول حتى لو جينا في الجماعه ديبريست كلنا بنتابع حالات اكتئاب في عياداتنا وفي المستشفيات الى اخره، هنجد مشكلتهم هتزيد بالنسبه للكاردياك بروبلمز. كتير منهم الهايبرتنشن بيبقى جزء من الاعراض، ولابد ان احنا المريض المكتئب ده نفحصه كويس قوي فيزيكالي زي ما بنسمع له ونقول ان عنده ديبريشن. لازم اشوف ضغطه في الزياره الاولى، لازم اشوف وزنه في الزياره الاولى، لازم اشوف كل العوامل البيولوجيه اللي عنده ديابيتس، عنده ارتفاع في الضغط، عنده اي مشكله اخرى في اي سيستم تاني، لان ده هينتراكت مع الديبريشن اللي عنده وهيعلي نسبه الموربيديتي والمورتاليتي واحيانا عدم استجابته للعلاج. In diabetes type 1 or 2, depression was associated with a significant higher risk of diabetes mellitus. Specific complications اللي مين من الديابيتكس اللي ممكن يبقوا مكتئبين اكتر؟ اللي عندهم الكومبليكيشنز دي ريتينوباثي، نيفروباثي، نيوروباثي. يعني كل ما الاعراض اللي هي كومبليكيشن اوف دايابيتس بقت موجوده في الدايابيتك كل ما نسبه اكتئابه عليت. طبعا طبيعي لما بيبقى فيه الكومبليكيشنز دي هتقلل من احساسه بالراحه، هتقلل من السيلف استيم، هتخليه دايما حاسس ان هو عنده مشاكل صعبه. والديبريشن is comorbid with diabetes mellitus lead to high death rates. نتيجه ايه؟ البور دايت، البور ميديكيشن ادهرنس، والفانكشنال impairment and higher health care costs. فاذا وجود الاكتئاب هيكومبليكيت المشكله. hospitalized elderly اللي هم فوق ال 65 لهم برضه مشاكل مع depression and are more likely to deteriorate, less likely to improve. Less likely to improve during after hospitalization and increased medical utilization and the risk of recurrent falls. recurrent falls يعني المريض كل شويه يقع، كل شويه يتكسر، فكل دي طبعا هتبقى مشاكل. الكانسر مع comorbid depression برضه higher risk of mortality, stronger hospital stays يعني بيقعد فترات اطول في المستشفى، و 43% of those with depression fail to seek treatment for their depressive symptoms. كنت انا في معهد الاورام وكان في مريض عنده يعني ستيج 3 او ستيج 4 بقى، وديسيمينيتد وتعبان جدا، ويعني واضح ان هو يعني امامه شهور قليله عشان يعني ربنا يفتكره. فبساله بقول له ايه رايك في الدنيا والحياه وبتاع؟ قال يعني الحمد لله على كل شيء. قلت له تفكر في انك انت تموت؟ قال يا ريت الموت يبقى قريب والواحد يخلص. تحب تموت نفسك؟ تحب تنتحر؟ قال لي لا ازاي؟ ده انا ابقى كافر. انا ما موتش نفسي. ده بيورينا ان كومباريزون المريض المصري وحته الفيث بالجهد وحته الفيث بالريجن وقد ايه بتاثر في تحمله للالام. هناك في كثير من الدول الاوروبيه على طول بيطلب الاسيستد سوسايد، يعني يطلب من الممرضه، يطلب من الطبيب يديني حقنه، يديني حاجه علشان نخلص ونعدي للناحيه الثانيه بعد بدل ما اقعد 6 اشهر كمان معذب، لا انتحر. بس الانتحار يبقى اسيستد، ده اللي احنا بنسميه اسيستد سوسايد. هنا عندنا طبعا البركه في الايمان والفيث الجود، بيخلينا من ايه ما لا نستسلم حتى لليأس في اشد اللحظات. Effective treatment في الميديكال comorbidity is equally important for the outcome of depression in diabetes mellitus. يعني طبعا لما بنعالج الاثنين، هنعالج الدايابيتس، نعالج الدبريشن، الاثنين بيمشوا مع بعض. وباي ذا 10th year of insulin dependent، الجماعه بقى اللي بياخدوا انسولين على طول بتبقى عندهم مشاكل طبعا في الدايابيتس يمكن اشد شويه. وحوالي 48% من اليانج دايابيتكس developed at least one psychiatric disorder with depression. the most prevalent فيهم بيبقى حوالي 28. في الكوشنج والاديسون والهايبوثايروديزم والهايبر برولاكتينيميك امينوريا، التريتمنت بتبقى برايمرلي بتادريس الفيزيكال كونديشن طبعا and may be more effective than antidepressant drugs for such organic affective syndromes. يعني هنا واحد عنده كوشنج لازم طبعا اعالجه، والاديسون نفس الحكايه، والهايبوثايروديزم والهايبوثايروديزم العلاج السبيسيفيك بيبقى مهم جدا. وكلنا فاميليار بالدبريشن وعلاقته بالهايبوثايروديزم، ولازم ياخد التروكسين بكميات متفاوته ما بين 50 و100 واكثر، والا الدبريشن هيبقى ريزيستنت. الكوست طبعا بتبقى عاليه، والديسابيليتي مع الدبريشن بتبقى اعلى. وهنا الدبريشن مع الميديكال كونديشن لازم نبقى قادرين على تشخيصه، لان احيانا كنا بنجد صعوبه، وخصوصا في جماعه بتوع الكانسر والادفانس كانسر، يقول لك ما بنامش، ما باكلش. يعني كتير من الاعراض في الدبريشن انه ممكن ما ياكلش خالص، ممكن يخس. طب يا ترى ده عضو، يعني ده عرض للكانسر ولا عرض للدبريشن؟ احيانا بتبقى المساله مش واضحه، ولابد ان احنا نبدا ندور على الكريتيريا الهامه جدا في الدبريشن، اللي هي نمره 1 و2. ايه؟ انا حزين، انا زهقان، انا متضايق، او لوس اوف انترست في كل حاجه، الحياه ملهاش لازمه، مفيش حاجه بليجرابل. هم دول التو كاردينال فيتشرز اللي لازم نحرص على ان احنا نلاقيهم في المريض عشان نشخص ديبريشن. انما ما اقول بين، اقول هيدك، اقول جاستروستاينال بروبلم، او انوركسيا، كل دي اعراض قد تكون لا علاقه بالمرض العضوي نفسه. الكويشنز اللي بتفيس الثيرابيست وهو في هذه الدايليما: does the patient manifest depression فعلا زي ما انا بقول؟ is there an organic cause as a medication that can be eliminated or treated؟ يعني بدور على حاجات ايتروجينيك او حاجات اخرى بيستعملها. does it arise from a medical condition زي الكوشنج او الهايبوثايروديزم، او treatment of a condition to alleviate it or must be treated itself زي post stroke depression. فهنا لازم افرق بين المرض وبين عواقب المرض، وعشان اعالج ده وده بدون ما ابقى وامشي في سكه واسيب التاني. زي ما انا قلت دلوقتي الديبريست مود والماركت diminished interest or pleasure in all or almost all activities، دي الكاردينال diagnostic features للديبريشن، عشان ما تهشي في الاعراض الاخرى للامراض الثانيه. ولازم افرق الديبريشن من الاورجانيك منتال سندروم، الديمنشيا، الفرونتال لوب سندروم، والانجر بيشنت في دارك ويز هوسبيتال انفايرمنت. يعني اروح مثلا لمريض قاعد في الاي سي يو، والاي سي يو بيبقى عباره عن حته كيوب كده، وفي 15 عيان وكلهم صاحيين وكلهم يعني متألمين، ويصحى الصبح يلاقي السرير اللي جنبه فاضي. ليه؟ اصله توكل على الله ومات واتشال. فالانفايرمنت ستريسنج، وهو ده اللي احنا بنسميه انجر فيت بيشنت في الهوسبيتال انفايرمنت. يعني ليس بالضروره ان المريض ده يبقى مكتئب، لا، ده الانفايرمنت نفسها ستريس. في بعض الامراض الخطيره جدا زي الكانسر والبنكرياس، الستروك، الديمنشيا، السب كورتيكال ديمنشيا، والاتش اي في. كل دول مشهورين ان هم بيبقى معاهم الديبريشن كوموربيد بشكل عالي جدا. برضو التشويس في الانتي ديبريسنتس لازم نبقى عارفين we should be careful على السايد افكت على دراج انتر اكشنز. لقوا ان الفلوكسيتين in obese diabetic patients has ameliorated the mean blood glucose levels with daily insulin requirement and glycomyoglobin levels by improving insulin sensitivity. إذا الانتي-depressant fluoxetine can beneficial حتى even for our treatment للdiabetic patients. التراي cyclic antidepressants ممكن بتورثن الجلايسيميك كنترول، وده معناه ان احنا we should select الانتي ديبريسنت اللي احنا عاوزينه. والاس اس ار اي فلوفوكسامين بتديكريز السيرم كوليسترول ليفلز، والتراي سايكليك انتي ديبريسنت بتزودها. اذا لازم نبقى عارفين احنا في الليزون انفايرمنت هنختار انهي انتي ديبريسنت نستخدمه. لازم ناخد بالنا من الويت جين، لان بعض الدراجز بتزود الويت جين ودي طبعا بتعمل لنا مشكله. من اهم المشاكل في الانتي ديبريسنتس ان ميديكال براكتس الاورثوستاتيك هايبوتنشن، لازم ناخد بالنا منها، والانتي كولينرجيك افكتس والكاردياك كوندكشن افكتس. يعني لازم نقرا كويس قوي ايه الحاجات اللي هي هنعتبرها سايد افكت، فلما يطلبوني اروح في ليزون ما ابقى فاهم انهي انتي ديبريسنت اللي هديه، لو هو في كاردياك لو هو في otherwise. In conclusion, depression in medical practice needs careful evaluation and more attention. Thank you very much.
Thank you, Professor Al-Nazim, for this very comprehensive overview of depression in medical practice. Now we'll have our next distinguished speaker, Professor Farid Talib from AEB, and the title of the presentation is Advances in Interventional Treatments for Mood Disorders.
Thank you. Again, I'm very happy to be here, and thank you for inviting me. I'm not going to name everyone because everyone was great. This is my first time in Cairo, and although Beirut is very close, but for some reason I never made it. So I'm very happy to be here. Thank you, Professor, for your very interesting presentation. I'm going to talk about many things. I'm going to cover advances, talk a little bit about history, and all the way to some very maybe futuristic things. You might find some things interesting, but we will tell you why. And so it is going to be an overview, and I'll be happy to share the slides later. Send them to the top. So, brief outline, history, some new medications, some new neuromodulation, interventional things, and some future directions. And we're going to talk about the AI in the end for you. Very briefly, as per the WHO, we have almost more than 300 million people have depression. Depression is notoriously hard to treat and a recurrent disease. At best, 50% improve. We always are stuck with remission rates which are low, and this leads to the risk, clinical challenge of TRD, treatment-resistant depression. And having resistant depression will lead to serious complications. First of all, worsening episodes, so the depression becomes more frequent and more severe. It can lead to substance abuse and sometimes, unfortunately, suicide. So, obviously, we are in the land of the pioneers in everything, including brain surgery. So the first evidence of brain surgery documented happened in ancient Egypt, and this seems to be an accurate description, and these were bones. So, but what does this tell us? That humans figured out a long time ago that most things are happening here. And they were curious enough, thousands of years ago, to try to manipulate the brain. Roman physicians figured out that electricity maybe plays a role. And the only source of electricity they had was the electric eels. They were shocking people in the head. Benjamin Franklin, not too long ago, also did it. And this term is now not appropriate, especially for our female colleagues, but this was a very common disease that was affecting females. So he shocked Benjamin Franklin, a woman, and because he discovered electricity also in the US at least, and she improved. There's a very interesting book, if you are interested in history. It's about the role played by electric fish in the early history of bioelectricity and medicine. And this is what they say, that they used to use the eels to shock heads to treat headaches. Okay? And one of the reference of that book is Arabic medicine. Okay, Hayat al-Hayawan. So if somebody is interested in history, there are books that look at these interesting things. I saw this picture in real life in a museum in Spain, and it also shows us that in medieval years, people started doing things more, and they figured out that seizures now seem to affect mental illness. So we started trying to cause seizures in people: insulin shock, insulin therapy, camphor, Kafur injections, and malaria therapy for tertiary syphilis or the insane, TPI, causing febrile seizures. So we inject people with malaria toxin. And this famous gentleman, he went on to win the Nobel Prize in medicine, Dr. Moniz, and this was a very simple procedure. It was done while awake. He has a hammer in his hand, and they would bring all the psychotic people in town. They would line them up, and he would remove their frontal cortex. And Dr. Egas Moniz won the Nobel Prize for medicine. It might seem cruel now and bizarre, but that was the only treatment until 1950, when the French discovered antipsychotics by accident. Now we still do lobotomies, but they are more sophisticated. So these are cingulotomies for OCD, and they are still done here. A very interesting story. I was having a dinner once. Actually, it was a fancy event, and this woman sitting next to me, very elegant lady, and she said, "Guess what I have done?" I have done a cingulotomy in the 80s. And she did a brain cingulotomy, and it cured her OCD. So we don't do these anymore a lot, but they are a refinement of the lobotomies. And this is the inventor of ECT, Dr. Seletti in Rome, and this is the first machine. They have it in a museum, you can see it. Functionally, ECT has not changed. We still do the same. The techniques evolved. Actually, at our department, one of our colleagues who left now was one of the pioneers in something called FEAST. So FEAST may be evolution of ECT. It is a big anode and a small cathode on the same side. So you imagine like a beam of electricity focusing on one point. And you can see the benefit here. So red is activation. So this is FEAST. And these are right, bifrontal, bilateral. So there is less red, which is better. So recovery time is less, and you need a smaller charge. This is magnetic, so there is no brain effect. So we actually participated in these studies, and you can do these easily. Existing ECT machines, you just change the electrode sizes. So now we'll talk. So enough history. We'll talk about novel therapeutics, and I'm sure you've all heard so much about ketamine now. And this is from a couple of months ago. It's on the front page of the NIH. So they seem to be very, very invested in new treatments, and ketamine seems to be something they are excited about. Ketamine is a glutamate antagonist, a simple anesthetic. They use it in veterinary medicine, and we use it in the hospitals. We are actually using ketamine, and we're trying different ways how to see what is the best way to use it. It seems the NMDA antagonism is not the main issue. That's not how it works. It seems to work mainly by producing BDNF and the rapamycin receptors and something called AMPA, which comes after NMDA activation. Okay? So it is not just about antagonizing NMDA. The antidepressant effects were first realized in 2000. So this is a study in 2000, and it was a single dose of IV ketamine, and people improved in 72 hours. To be honest, we've tried different ways and formulations. We work closely with anesthesiology, but we are not, again, seeing the miraculous results that are being sent to us from abroad. But we are still, we're not giving up. So this is the study that really led to the approval. so giving the infusions. We are now jumping to this with what Dr. Tamer mentioned. I think the jump to this is because of cost. IV intravenous ketamine costs nothing, a few dollars, $2 maybe. This now is being sold for almost $1,000, the vial. So they made the S isomer intranasal and we're injecting it. And it's more complex to use. Evidence shows that IV ketamine is more effective than intranasal. Just like briefly about dosing, the basic APA statement is 4 IV infusions, 2 each week. If things are not improving, you probably should stop. The intranasal makes it much longer. 2 per week for 4 weeks, then 1 per week for 4 weeks, and then 1 every 2 weeks. So you're talking about many little bottles, each one costing almost $1,000. The whole thing would cost maybe $10 if you look at medication bans. However, there are many limitations for ketamine. We are thinking of it as an acute intervention, like maybe a medical ECT. It's not sustainable. It is a drug of abuse in Lebanon. It's widely abused by young people. It's a super K, okay, and they take it in parties. Long-term effects, we don't know. I'm going to talk about this interesting medication for specifically one indication. This was approved very recently, brexanolone, just for postpartum depression. It's 1 infusion, 60 hours long. It costs $30,000, the 1 infusion. This is a novel medication, brexanolone. It's analog of progesterone. It falls under the neurosteroid categories. It seems to modulate GABA, but we don't know how it works, really, as it's extremely expensive. But it seems to be something that can be used for severe postpartum depression. I talked about this briefly upstairs about when we talked about drugs, but these medications are making a comeback. MDMA, LSD, ecstasy, all these were actually invented in the 60s as therapeutics, then abandoned. And now, because we're stuck, we can't find new medications, and therapy has limitations, so we're experimenting with all these things. Psilocybin, which is similar to lysergic acid LSD, seems to be helping some cases of persistent depression, anxiety, maybe addiction. We don't really know how it works, but it seems to flood the brain with serotonin. They are not very addictive, actually, and not much physical harm, so they're not dangerous. They are trying microdosing in therapy. We actually were contacted by somebody from the US if we would like to be a site to participate in a study, but we can't do that in Lebanon. MDMA, ecstasy, it's a party drug. Again, it's making a comeback. Small doses with therapy, they seem to be effective. However, it is not a simple drug. It can cause serious side effects. There is now an FDA exception for MDMA, and they gave them fast-track approval. However, the Americans' interest in PTSD is more for soldiers and combat, so they're desperate to find treatment for because they have a very, very high rate of suicide in the army. So anything that relates to PTSD, they want to treat it. Their perception of PTSD is more for the soldiers, not for the individuals like we deal with. So this is the study, if you're interested to read about it. So they gave PTSD session CBT, and every 3rd session they would give microdoses of MDMA, and the people in the MDMA group, ecstasy, did apparently very well. But again, if you're going to take ecstasy, you're going to feel good. So now this might be interesting and maybe feasible to do. Low-dose buprenorphine, the medication we use to treat addiction and opiate addiction, Suboxone. Giving very low doses seems to help by activating opiate antagonists, the mu receptors, and antagonizing the unpleasant ones, kappa and the delta. People do abuse it, but it's not very abusable. It's relatively safe, it's sublingual, it's not expensive. Combining it with naltrexone seems to help with self-injurious behavior. So for people who have self-injury, maybe borderlines who are depressed, you can consider giving it. Okay, so there's significant research that it does help and can reduce suicidal thoughts. talk about neuromodulation now, which is exciting and interesting because again, like the debate we witnessed, psychiatrists are desperate to become real doctors. So we're just looking for things left and right to show our colleagues. And so we're going to talk about these things briefly. This is VNS. I think most of you have heard of it. Maybe it's approved for seizure epilepsy treatment. So it's a little thing you implant it under your chest like a pacemaker. There is a wire under the skin, and the wire hooks to your vagus nerve. And it seems to work. However, it is not a joke. It's surgery, and if you risk of infection, and you're wrapping metallic wires against your vagus nerve. Left vagus is usually used, and it's less affecting the heart. But you can still have heart. The idea is the signal goes up, but the vagus also goes down. So you can shoot signals down, stop your heart rate, have a heart attack, or your voice, like my voice, will start to crack because the laryngeal nerve is affected by the vagus, so some anatomy. It seems to, in the beginning, it seemed to be not effective. So now it seems the effects of vagus stimulation takes time. So we're talking at least 4 months to get effects. And the mechanism of action is retrograde stimulation of the forebrain. And it seems to be effective long-term as an adjunct therapy in treatment-resistant depression. So you're not going to put the VNS device and cure people. But it can help very sick people become a little bit better with other medications. So again, VNS seems to work as a long-term therapy. Okay, so you tell the people you're going to put this for years, and it will help you be better over time. This is an interesting device. This might put Ritalin out of work if it takes hold. This device was approved very, very recently. It's called ETNS, extra trigeminal nerve stimulation. You hook this patch to this device, and you sleep, and it cures ADHD. If ADHD is a disease or not. You're making me doubt everything I say now. So, ETNS was approved in the late 2019, just maybe 2 months ago, for ages 8 to 12. And by this study got FDA approval. So they did a sham double trial, double-blinded placebo-controlled study, and the kids who slept with this patch had effects similar to improvements on scales and stuff, similar to the medication. So if you tell a parent, you put this little sticker on his head, or you give him medicine, I think most of them were going to take the sticker. So device companies now are competing with the drug companies. Okay, so this is called ETNS. This is my nanny. So this is my research assistant. She's not a patient, so we don't have to blind her face. And this is our TMS machine. Again, we're talking among colleagues. TMS has not been, again, so great. And this machine is very expensive. Now we have to go train to use it. And people come excited to us. I have a relative, he keeps on harassing me, he wants to do it. And I don't want him, it's our culture like here. I don't want to get into that because he's obsessed with doing the TMS, and I don't want to do it because I know it's not going to work for him. So this is the actual machine. You sit. It is non-invasive magnetic coil. It penetrates your cortex 1 to 2 centimeters. Does not affect subcortical. It's very safe. Little or no side effects. We try it on ourselves for fun, and with the students. If you put it over your occipital lobe and give a little pulse, you see phosphines lights. Something fun. If you put it on Broca's area and turn it inhibitory, people cannot speak. You stop them from speaking. So it's fun, and but it does work. It does work in mild to moderate cases. It's a very expensive toy. This is what hella we are calling it in the department. Okay, but there are lots of studies again. Many studies that pushed for approval in 2009. But approval was delayed for TMS. They struggled a lot to get it approved. It might help TRD, resistant depression. Some evidence for anxiety, but in my experience, it does nothing for OCD. Some people are so desperate, they're insisting. In our culture, people like medicalization. We're having Arab nationals from the Gulf, from people living abroad. They see it on our hospital now is very big into social media. So you can follow us on Twitter also if you want. So they advertise for these things. So we have this Lebanese person came from Switzerland and they wouldn't do it there, but he insisted. وبعدين واسطة تدخل يا أخي بدك بعمل لك إياها. Come do it. And he spent 2 weeks and left. Because apparently it's very expensive over there. So it's not a substitute for ECT. It is not a substitute for ECT. And there are some studies that using it with ketamine will maybe help. It does work for pain. We're trying to utilize it with our anesthesia pain management team. Okay. So you do repetitive TMS. If anybody's seen it or heard it, it's like just giving me these rapid clicks, magnetic pulses that change into electrical waves under the cortex. It's time intensive. You need at least 2 weeks, and the session takes up to 40 minutes. It's safe, no seizures, patients are awake, no sedation, no IV. It's expensive, requires training. The only absolute contraindication is any metallic implants, plate in the head, screws, or anything like that. Incidentally, in Lebanon, because of the war, we have many shrapnel injuries that are undetected. So many Lebanese people have metallic things in their heads. My mother last year was going to have an MRI, and then the image was completely blurred. She had like a shrapnel in her head from the Lebanese war. They used to like bomb civilian areas. So you'd have little pieces of metal in people's heads, and so this is a cultural problem we have. So the new type of new type of TMS we have is called ITBS. It's just a programming thing. Our machine can do it. The interesting thing about intermittent theta burst stimulation is it compresses the time of the session from 30 minutes to less than 3 minutes. So this might be helpful because you can do much more sessions quickly. You can compress the whole thing into maybe 1 week because it's just 3-minute sessions, and you can do 4 3-minute sessions in 15 minutes, and you save lots of time. So we are trying to experiment with this. It's called intermittent theta burst stimulation. Okay, so ITBS seems to work, and there's evidence now, new evidence, 2019, that it is more economical and cheaper. These things tend to work more in the first world. I don't know why. So this is a new technology called Deep TMS. Other than looking funny when you use it, it supposedly helps OCD because this Deep TMS goes subcortical. So our devices, the ones we have, are cortical. They just go into the cortex. This can go deeper, and theoretically it can create conditions like OCD, and we know the circuit well. We don't have it in Lebanon. In Lebanon we have an embargo with Israel active, so the only device company that makes it is Israeli, and we were unable to get it because it's okay. So apparently this one is painful. This is a new technology that might be you might recognize the bite guard. This is called magnetic seizure therapy. So you do the seizure, but not with electricity. So you get the same effectiveness, same results, without the damage of electricity to the brain. Because the ECT symptoms, memory, confusion, are all related from the electricity passing through the brain tissue. So this is actually the same machine we have, it's a little modified. And you use these magnetic pulses to create a seizure. So the seizure is created with magnetic waves, not electricity. And again, you still have seizures. So it's called MST, and this is also a very recent study from 2020, January 2020, that shows effectiveness and response and little or no side effects. So this might be promising as a replacement for ECT. So again, another study for magnetic seizure therapy for treatment-resistant bipolar depression. This is something it's very common now. It's called transcranial direct stimulation. You can buy it online.
What are the results of
They were positive
Oh.
for in both studies for magnetic seizure therapy. This is from Neuropsychopharmacology, and this is from Journal of Psychiatry and Neuroscience. Both were positive. and
That's
had
cognitive impairment.
was very minimal.
Uh-huh.
Okay, so so it is promising. I think it might replace ECT. This is simple. You can buy these online. They sell them for kids' cognitive enhancement. It's a 9-volt battery, and you put little stickers on your head, and apparently it cures everything. It's called transcranial direct current stimulation. It's very safe. It's not harmful. But people did study it. You can go on Amazon or these things, and they sell them. You can easily buy it. It may be effective for depression. This is from Encephal. It's a French publication. They reviewed the literature. But the selling point is cognitive enhancement. That's what they sell it over the counter. You can buy it by a prescription. But it does not work for cognitive enhancement. It might improve slightly depression, but it's very, very weak evidence. Okay? And this is now the most invasive thing, DBS, deep brain stimulation. We do this for Parkinson's, and we do these in our university hospital, but we do not do them for any psychiatric disorder. So you implant these probes in the skull down to whatever area you want. So the problem in psychiatry, in Parkinson's, they know where to go. In addiction, I showed earlier, you can go to the nucleus accumbens and you stop addiction. But for depression, again, psychiatrists start arguing with each other. The DBS in the US has an FDA exemption for depression as a humanitarian device. There are now maybe around 1,000 cases have been done. Not a huge amount, but enough. And there are serious side effects. It's a brain surgery. And it's very expensive. And there was lots of back and forth that it doesn't work, it's not doing anything. But now long-term evidence is showing that it is working. But it depends on where you put it. And all these are different groups. We're not going to talk about each one. So I was in Cleveland Clinic for many, many years, more than 10 years, and they used to do it. We used to do it apparently in the wrong area, Cleveland Clinic. Ventral capsule of the striatum. The area that seemed to work long-term is this. Subcallosal, subgenual. So the area just below, the nuclei just below the corpus callosum. All the others were not effective. So when they have now long-term data, it seems to be effective if you remove the wrong sites. Okay. So with miniaturization, can you put these little probes inside and fix depression and everybody's going to be happy? I think this might be the only way to go beyond the debate of spirituality and right or wrong. Just put little electrodes in all these areas and we'll all be running around happy. Is it possible? I'll show you something interesting now. So this is also very recent, and this is from 2019, where we finally have evidence that DBS might actually work, deep brain stimulation. Okay, looking at the subcallosal cingulate. People have been implanted for 8-10 years now. So we're going to talk about one last thing, which is maybe a frontier. It's called optogenetics. Optogenetics is a tool in neuroscience. I'll discuss it very briefly. So you know the fireflies, the mosquitoes that glow in the dark at night? You remove that protein, light-sensitive proteins. You link them to a virus, transfect them in the brain to the area you want. So you can send it to the nucleus accumbens area. And then you insert a fiber optic laser, fire laser, the light-sensitive protein works, and you activate the area. Okay? It's very, very impressive stuff. It came about in 2005. So you need a protein, a receptor, and an injection, and a laser. So this is simple. Okay? So you put the promoter, the light-sensitive protein, injected where you want. And then, this is the mouse. It's very advanced. I'll show you a video now, if it works. So this is how you shave their head first. And now, this is the fiber optic. The new ones are implantable. There's no cable. It's just a little cap on the mouse's head. Okay, so this is fiber optic laser. And this is what's happening in the brain. This is next to the ventral tegmental area. So this is the probe head, and it's lighting. And the area now, the protein from light sensitive is going to be activated, and it should start pumping out dopamine. Okay, and this is when they turn on the laser. Mice don't walk in the daytime. This is a mouse sham. So when they turned on the laser, the mice start to walk around. So you're pumping the mouse with dopamine, you overcome the fear anxiety reaction. So if you postulate that fear in mice is anxiety, you can override it. So can we implant these in different areas? If you're starting to feel anxious, you turn on the light switch. If you're sad, another area. So there are lots of studies in animals. Addiction, aggression, sleep. The one in sleep is very interesting. You turn the on-off sleep switch with hypothalamus. They fall asleep, they wake up. Food, they stop binging and they made them eat. There is cocaine. We were just mentioning that cocaine has no obvious treatment. But they were able to stop cocaine behavior in mice with this.